Sir, you can go live.
Yeah. Hi, I'm Dr. Santosh, Consultant Emergency Physician, Yashoda Hospitals, Secunderabad. We welcome you to our Experts Appraisal on Emergency Medicine webinar, which we conduct on every Friday. So, as we know, point of care ultrasound, it enhances patient care by acting as a rapid diagnostic tool, rapid diagnostic tool, and it helps in frequent as a hemodynamic assessment and hence improves patient care. So, to discuss this vital topic, today we had Dr. Niranjani, Associate Consultant, Max Super Speciality Hospital, Nagpur, to discuss with us. From hereby, I request Dr. Niranjani to take over.
Good evening to one and all, and thanks a lot, Dr. Kiran sir and Yashoda team for giving me this wonderful opportunity. Today I'm here to speak about the use of point of care ultrasound in emergency medicine. Basically, I'll be dealing with this topic as it will be useful for the beginners who are trying to learn POCUS, and that would be my major aim. So moving ahead. POCUS is mainly, it refers to the use, next slide, please. Yeah. I suppose the next slide is visible to everybody.
Yes, it's visible. It's visible.
Yes. So mainly POCUS is point of care ultrasound, which refers to use of ultrasound at the bedside for immediate diagnostic and procedural purposes. As it is a bedside procedure, it's very easily available and can help emergency physicians diagnose many important things on the go at the bedside when we are at diagnostic dilemmas. So basically now it is a real-time, POCUS is a real-time visualization of anatomical structures and the physiological processes. And as we all know that POCUS has actually evolved as a valuable tool in emergency medicine, as it is offering immediate diagnostic insights, and it improves the patient care also. Next slide, please. Next slide.
Yeah, just a second.
So as we all know, POCUS is a portable machine and a compact ultrasound device which can be used at the bedside, as I already said. So you can see three types of ultrasound devices that are available for point of care ultrasound. They are compact, cart-based, hand-carried, and handheld or pocket-sized, which are the most recent ones. And the recent ones are already supplying artificial intelligence also with them. So there are types of probes next, which we deal with. So the ultrasound probes, as we all know, include three types of major probes that are linear, phased array probe, which is also known as the cardiac probe, and the curvilinear probe. And each has its own specific applications. Next, going ahead with the technique, you have to know the mode of ultrasound also to be a for a proper image acquisition. So the modes of ultrasound are B mode, which is the brightness mode, M mode for the motion mode, and the Doppler mode. Doppler modes are these three modes are basically utilized for imaging and assessing various anatomical structures and physiological processes. Next slide. Yeah. So in this slide, you can see the three different types of probes. The first one being the curvilinear probe. It has a low frequency and a wider footprints and is used to see deeper structures. The linear probe has high frequency. It is a linear footprint and can see shallow structures less than 8 centimeters. And the phased arrow probe, which is also known as the cardiac probe, as I already said, is a low frequency probe which has a narrow footprint but can visualize deeper structures. And in the corner image, you can see a butterfly kind of a probe. It is a all-in-one handheld probe, which is the most recent one This can be connected to your mobile phones, and through smartphone apps, you can use it for imaging. Next slide, please. So going ahead with the interpretation and the POCUS images should be interpreted actually in the real time. And for that, students should know the anatomical landmarks and should able to recognize the artifacts and the physiological changes that are going ahead. So the tips for acquiring high quality images are: the probe should be positioned properly and the gain settings should be made properly. Patient positioning is also essential for obtaining a clear and accurate ultrasound image. So understanding all these things, understanding how to position the patient, how to optimize the gain settings, what are the knobology, is very important for accurate interpretation. Next. Yeah, as you can see here, the basic knobology includes depth, axis, and gain. You can remember it as DAG. So depth can be increased or decreased depending on what you have to visualize. Axis is by moving the center of the probe for getting the proper axis. And by gain, you can increase or decrease the brightness. So you can visualize the images properly according to the brightness which you want, which you can properly visualize. Okay, also in this slide, you can see the frequencies that are being given for different probes. The curvilinear probe, a frequency of 2 to 5 megahertz. The linear probe has 5 to 10 megahertz of frequency, and the cardiac probe has 1 to 5 megahertz of frequency. Also, here comes echogenicity. What is echogenicity? Echogenicity is basically brightness. Hyperechoic means it will be more brighter than the surrounding structure. Hypoechoic will be less brighter or darker than the surrounding structure. And anechoic or isoechoic, anechoic will be devoid of any echoes. That is, there will be no blackish areas. That is known as anechoic structure. And isoechoic is almost equal echogenicity to the surrounding tissues. So basically, for a cardiac view, we generally take three windows. There are parasternal, apical, and subcostal views. So when you keep the probe on the patient, there is a marker on the probe. So that marker has to be oriented properly. Generally, the probe marker will correspond to the marker which is on the screen of the ultrasound machine. And the topmost layer, that is, the probe will show the nearest organ of the body most superiorly. That is, nearest to the probe will be seen most superiorly. Next. So to obtain a proper image, you actually have to do some manipulation or movements with the transducer. So some of the manipulations which you can do for a proper image acquisition is sliding, by sliding left or sliding right, sliding up or sliding down. You can also tilt the probe, that is also known as spanning of the probe. Okay. And you can also rotate the probe. You can rotate the probe and you can rock the probe. Rocking is front and backward movement of the probe. Next. Going ahead with the applications of POCUS in emergency medicine. As we all know, nowadays a POCUS or an ultrasound machine is known as the new stethoscope for emergency physicians. It is because it has a wide array of applications in for us as emergency physicians. So some of the applications that we already know are fast examination that we do, that is focused assessment in sonography that we do for trauma patients. Basically for intra-abdominal bleeding in trauma patients, to diagnose intra-abdominal bleeding for trauma patients. E-fast examination is an extended version of the fast examination, wherein with the fast examination, that is with the abdominal examination, you also go ahead and do a lung ultrasound. This is mainly to diagnose pneumothorax or hemothorax in addition to the abdominal examination that we are doing in the fast examination. There are several protocols that have been developed in POCUS, which can be used for diagnosis of shock also. For any undifferentiated shock, there are multiple protocols like RUSH protocol, ACEs protocol, shock protocol. All these protocols basically evaluate the cardiac function, the cardiac volume, and the vasculature, basically the vasculature in the whole body. The major vascular structures are evaluated in these protocols, which I will be dealing with in the further slides also. Another use of POCUS is the cardiac ultrasound. Cardiologists and we as emergency physicians are regularly doing cardiac ultrasounds in emergency to diagnose multiple like myocardial infarctions, the heart failures, cardiac arrest. We are using them in multiple utilities for cardiac ultrasounds also. Lung ultrasound has also shown a lot of what would I say, many good results that it is aiding in early diagnosis of many conditions like pneumothorax, of course. Other than pneumothorax, pleural effusion, pneumonias, consolidations, any diagnostic dilemma where we are having between ARDS or pulmonary edema, lung ultrasound is very helpful in these cases also. Next use is a vascular ultrasound. We emergency physicians generally use ultrasound machines for guided vascular access. Other than that, it can be used in protocolized based diagnosis of DVT or pulmonary embolism also. Next. So coming to the most common examination that we all do is the E-fast examination. This image that you see on the screen is basically the position of where all the probe should be kept. Okay. For a E-fast examination, we generally use a phased array, that is a cardiac probe. It can be used for entirety of the exam as it has a deeper penetration. Also, curvilinear probes can be used, but the cardiac views with a curvilinear probe is a expert-based, operator-based view which can be obtained with experience. So to start with, I would always say a cardiac probe should be used so that it can be used for the entirety of the examination. So in an E-fast examination, on the machine, you have to preset the function for a fast examination or an abdominal examination, depending on the company of the machine you are using. Okay, and the ultrasound machine should always be placed on the right side of the patient, and you per se or the operator per se should be operating the machine with the left hand. So the first position that goes for the E-fast examination is the right upper quadrant position. So for the right upper quadrant position, you have to keep the probe on the right on the anterior axillary line or the mid axillary line in the almost 9th or 10th intercostal space, so that you can visualize the liver from there. So when you first visualize the liver, little bit you have to fan the probe so that you can see the liver and the kidney and then the Morrison's pouch. Okay. The second position will be the left upper quadrant. For the left upper quadrant, you have to go a little above, that is almost near the 8th intercostal space, because the spleen is placed a little bit higher. So to see the splenorenemic space, you have to go a little bit higher on the left side and posteriorly. You have to almost, your knuckles should touch the bed is the go. Actually, when the knuckles touch the bed, you're almost posterior, and then you can visualize the splenorenemic space. The third will be the pelvis. To see, you have to see the pelvis in a longitudinal or transverse position. You can visualize the bladder from that position. The fourth position will be the cardiac. You have to go from the subsid point. So you have to basically keep a probe go from below towards upward until you are visualizing the four chambers of the heart. This is a subsid point. Now, Other than that, in the first examination, you always see the lungs. So the lungs, you have to probe on the second intercostal space.
Ma'am, your voice is breaking.
Okay. Okay. Here. Hello. Am I audible?
Yes.
Yeah. So I was saying for the lung examination in a E-fast, you have to keep the probe on the second intercostal space, mid-clavicular line, both on the right side first and then on the left side, to rule out pneumothorax in an E-fast examination. Okay. Next slide, please. Next slide. Next slide. Yeah. Yeah. So here is the view that you can see. This is the right upper quadrant, as I said, the first view, the right upper quadrant view. And as I said, the marker should be pointed towards the head of the patient, head end of the patient. The marker of the probe should be towards the head end of the patient. So from the head end to the foot end, as you can see, from the nearest to the farthest, the lung. After that, the lung hyperechoic line is present, which is the diaphragm. Post the diaphragm is the liver and the kidney. If you can appreciate the liver and the kidney according to the echogenicity, and a bright hyperechoic line which comes in between, which is a Morrison's pouch. This is a normal right upper quadrant view. Next. Yeah. So here you can see a pathology. Can anybody say what exactly it is? Okay. So this is actually fluid in the Morrison's pouch or near the caudal tip of the liver. This is the view we will get if there is a fluid accumulation in Morrison's pouch or at the caudal tip of the liver. Next. Yeah. This is the left upper quadrant view, which is the normal view. From the left upper quadrant, as I said, from the head end to the foot end, from the nearest to the farthest on the screen, will be the lung. Post the lung, the diaphragm. Post the diaphragm is the spleen and the left kidney. Okay. There is a very small bright line between the spleen and the kidney, which separates. This is the fascia. So next, when we look for the pathology in the next, yeah. So when we look for the pathology, we have to see between the line between the diaphragm and the spleen, that is the perisplenic space, and also the line between the left kidney and the spleen. As you can see here, there is a fluid accumulation in the below the diaphragm and the spleen, and also the fluid extends up till the space between the left kidney and the spleen. Okay. Yeah. Next. Okay, so this is your longitudinal bladder view. For a longitudinal bladder view, you have to keep the pointer towards the head end of the patient and longitudinally over the pelvic area. Okay, just above the pubic symphysis. From anterior to posterior, you can see the structures. This is a male pelvis. So you will see a bladder. Behind the bladder, you'll see the prostate. And just in front of the prostate, behind the bladder, you'll see the retrovesicular space. Okay. Next. Yeah. So this is a female pelvis in a longitudinal view. So in a female pelvis, rather than the prostate, you will see the uterus. So this is the only difference between the male pelvis and the female pelvis in the longitudinal view, that you will be seeing uterus rather than the prostate. Okay. And behind the uterus, you can see rectum or the bowel gas also. Next. So this is the transverse view. This is a transverse view of the pelvis, normal transverse view of the pelvis. So you can see bladder, behind the bladder, uterus in the female pelvis, and prostate in the male pelvis. And behind the structure, then it becomes the rectum. Next. Okay. So this is a male pelvis which shows fluid collection in the rectovesicular pouch. If you can appreciate the hypoechogenic blackish structure that is moving behind most posteriorly, that is the fluid collection which you can see in a fast examination if it is positive. Next. Yeah. Again, a longitudinal view of the fluid collection. Always remember, when you see the pelvic area or the bladder area for fluid collection during a fast examination, when you keep the probe either in the longitudinal or in the transverse position, you have to always fan the probe. As I said, you have to do this motion, fanning motion of the probe, not to miss the lateral most aspect of the bladder where the fluid can collect in the initial stages. So you have to fan your probe in the longitudinal or in the transverse position so as to see the fluid collection more clearly. Next. Okay. So now we come to the next probe position, that is the subxiphoid view. Okay. So this is the subxiphoid normal view that you can see on your screens. So from the nearest to the farthest, because we are seeing from the subxiphoid area, you can also see the liver. Okay. You can see the white hyperechoic region, that is the pericardial layer. And post that pericardial layer, then you can see your four chambers: the right ventricle, left ventricle, and the right atrium and the left atrium. Next. Yeah. So can you tell which cardiac view is this? Okay. So this is the parasternal long axis view. Okay. As I told you, always try to know which view it is by seeing the nearest structure. The nearest structure here is the right ventricle. Okay. So when the nearest structure is the right ventricle, obviously you can anatomically think that where the probe might be kept. So the probe, wherever the probe is kept, the nearest organ or the nearest part of the body will be the superior most, as I said. Okay. So here it is a right parasternal long axis view where you can see the right ventricle, left ventricle. The lowermost hypoechoic area is the pericardium, and between the left atrium and the left ventricle, you can see the valve which is fluttering. Both the sides, you can see both the valves, aortic valve and the mitral valve. Next. Yeah. So now this is the subxiphoid view which you are seeing. So can you appreciate a very small cavity which is beating and a fluid collection between two white lines? So that is a pericardial fluid collection. So this is how a pericardial fluid collection will look in the screen from a subxiphoid view. Next, please. Yeah. This again is the parasternal long axis view, as I already told how to identify. Here you can see both the ventricles are underfilled and even there is a RV collapse. The right ventricle, which is the uppermost part, there is a collapse. It's not properly filling, neither it is pumping. It is completely collapsed. So this is a sign of, and the fluid accumulation is also seen in the pericardial layer. So this is a sign of cardiac tamponade. This is a very classical sign. Next, please. Okay. So next, as I said, next will be the lungs. We have completed 4 positions: the right upper quadrant, left upper quadrant, pelvis, and the cardiac views. That is a basic fast examination that we do. For E-fast, we go ahead for a lung examination also. So for the lung, first of all, you have to, when you are seeing properly, if you are acquiring a proper image or not, you can see by seeing this bat wing sign. What is a bat wing? Bat wing means a rib, the rib shadow, and the intercostal space in between where you can see the lung pleura moving. So this appears as a bat wing, the 2 ribs being the wings of the bat. So hence, when you see this sign, you can appreciate that yes, you are seeing a proper lung in between the intercostal space. You have to visualize the 2 ribs to see the lungs properly first. Next. Okay. So can you all see something, a hyperechoic white line, and the below space is moving with the line. Okay, and the movement of the below structure looks like something like marching of ants. And how the ants march on a single line, it looks like that. This is a normal lung sliding. Lung sliding on the screen on POCUS assessment or on an ultrasound assessment will look like this. Next. Okay. So what do we look for in lungs in an E-fast assessment in a trauma or when we are suspecting something in a respiratory distress? Okay. So here, as I showed in the initial image, you had seen something marching. Here also you can see a white hyperechoic line. But can you notice the change that here the ant marching or the movement of the lungs is not seen? If that's appreciable with the arrow exactly where I show, that's known as absent lung sliding. The lung below is not moving with the respiration. This is what happens to a patient when the patient has pneumothorax. There's absence of lung sliding on the lung ultrasound. Next. Yeah. So when we talk about the lung ultrasound, when we go towards the CP angle, that time you can see a mirror image kind of appearance wherein the mirror will be the diaphragm. So above the diaphragm and below the diaphragm, you might see almost similar kind of structures. So according to the echogenicity. So this is generally known as the mirror image artifact. This is very normal. This is a normal finding actually. Next. Yeah. So as I told you, at the CP angle, a mirror image artifact. But if you're seeing patient's spine on the ultrasound, that is something abnormal. That means there is some fluid collection, as you can appreciate here also up the diaphragm is a little bit of fluid collection that can be a hemothorax if it is a trauma patient. So when a fluid is present, the ultrasound penetration is much more better. So that is why you are able to see the spine also of the patient. This is known as a spine sign, which you can see in an hemothorax and all. Okay. So this is how the spine sign will indicate that there is fluid in, even if you don't see the hypoechoic or fluid blackish structure on the corners of the screen. If you're seeing a spine, 100% that is not normal. You have to look about other fluid or any consolidation or anything, pleural effusion, hemothorax kind of thing. You have to 100% rule out. Okay. Yeah. Next, please. Okay, so as I spoke about the modes, there are specific buttons on the ultrasound machine where you can change the mode. Okay, so as I told, M is for motion. When you have to see the lung, you have to see it in M mode because lung is a mobile structure. So you have to see it in M mode so that you can see the movements also. The physiology is better seen in the M mode. So the normal M mode of the lung will be as shown to you on the screens. It will be a seashore sign. Okay, seashore sign is the upper, as it is marked on the screen, upper area looks like sky, in between oceany texture, and the below portion looks like a grainy, sandy texture which is seen in the beach. So hence it is known as a seashore structure, which corresponds to the layers of the lung, and the movement of the lung. So this is a normal seashore sign that you see on M mode of lung ultrasound. Next. So to see either in the M mode, exactly you have to place your cursor between the two ribs in the intercostal space. As in the screen, you can see a green line is passing. You have to place it like that to see the M mode. Okay. So when you place it like that, in the M mode, if it is a normal lung, you can see seashore sign as shown in the previous slide. But if there is any pathology, example a pneumothorax, you will be seeing a barcode sign. Okay, the seashore will be vanished. Everything will look similar like a barcode, just like lines like a barcode. Okay. Next. Ultrasound going ahead also can diagnose pneumoperitoneum for you on fast examination. So this is an example for that. This view is also known as enhanced peritoneal stripe sign. The white arrows that you can see on the screen is the enhanced hyperechoic airy texture that you can see in the abdominal area. If you place your probe above the liver in the Morrison's pouch, as shown in the left side of the screen, you can see extra lines which are extending up to the liver, extra horizontal lines that are extending up to the liver. That is the enhanced stripe. It is like the stripes seen in leopards and cheetahs. So hence it is named as enhanced peritoneal stripe. If you are suspecting a pneumoperitoneum in a trauma patient, you can see this sign. Next. Yeah. As I told you, for the cardiac tamponade, the right atrial systolic collapse is most sensitive. Echocardiographic finding. It is also known as a trampoline sign. And the right ventricular diastolic collapse is the most specific sign for the cardiac tamponade, as I showed you in the image earlier. Okay. Next. Okay. So there are a lot of protocols that have been developed over the years by multiple research, and we as emergency physicians basically use POCUS for three major diagnostic purposes. Okay, so the diagnostic purposes come in wherein we are in dilemma. Like in acute respiratory failure, where we don't know the reason for the respiratory failure. Is it cardiac? Is it respiratory? Or is it obstructive reasons? Okay, so in this place, the blue protocol is very helpful. In the blue protocol, as you can all see on the screens, it is mainly based on the lung sliding. Depending on the lung sliding, if it is present or absent, and A or B profile. B profile is basically what you see in lungs. There are multiple horizontal lines extending from top to the bottom of the screen. And this happens when there is pulmonary edema or fluid accumulation per se in the lungs. So that is actually known as a B profile. Depending on the profile, actually there are A, B, and C profiles, and depending on that, you can come to a diagnosis based on the blue protocol. Next is the rush protocol. Sorry, you can go to the previous one. Yeah. The next protocol that we basically use in ER is for undifferentiated shock, that is the rush protocol. Rush protocol basically sees the pump, tank, and the pipes. Pump is visualized for how is the pump capacity, how is there any effusion, how is there any strain in the pump, that is the heart basically. The tanks means the inferior vena cava, the superior vena cava, and the drainage which generally comes to the tank, that is the heart. And the pipes are basically the aortas. Okay, so this is basically seen in the rush protocol. I will be discussing rush protocol in the further slides in a detailed manner. Another protocol that we see in ER, use of POCUS in ER is for a cardiac arrest patient. When a patient is in cardiac arrest, basically an non-shockable rhythm, and you have done certain things, but you want to go to a proper diagnosis. So during the CPR, you can use POCUS assessment to find out the cause of arrest. You can differentiate the 5Hs and 5Ts based on the findings in the POCUS. Okay, next. So there are multiple studies going on for the cardiac arrest protocols, and there are multiple protocols that have been developed over the years depending on these researches. Some of the examples will be a Sesame protocol, as I told you, the COS protocol initially. So the COS protocol might seem a detailed one, or the CASA examination we generally say. It is a cardiac arrest sonographic assessment examination. So basically, what do we do when a patient is arrested? What do we do with the POCUS is, first we see for the cardiac tamponade. From the subxiphoid view, you generally see for the cardiac tamponade within 10 seconds. You should not be stopping the compressions for the ultrasonic view. Okay, this is the major limitation for POCUS assessment during a cardiac arrest, because it needs a lot of experience and expertise to gain that view in such a small time. But that comes with experience and usage in regular assessments. Okay, so the first thing you see in a CASA examination is cardiac tamponade. Because why it is placed at the first priority is the most reason for pulses activity is cardiac tamponade. Okay, so that is why we rule out cardiac tamponade at the first. Then after 2 minutes, ACLS protocol has been continuing. Next, break whenever there is a pulse check. You can check for the right heart strain. Why do we check for the right heart strain? Is basically to rule out pulmonary embolism as a cause of arrest among the 5Hs. And last and not least is the cardiac activity. Why is cardiac activity kept at the last? Is because when you see a pseudo PEA and cardiac activity is there is much possibility of attaining a ROSC in that patient, and you should continue the resuscitative attempts for a longer time in a patient who has pseudo PEA. That is, the monitors are showing PEA, but the ultrasonic examination is showing a cardiac activity. That is a pseudo PEA. So in this scenario, you can continue the resuscitative efforts for a longer period of time. But if the cardiac activity is not there, you can decide on stopping the resuscitative efforts depending on how long you have given the resuscitative efforts according to the ACLS protocols. Also in the CASA examination, you can extend your examination to rule out a pneumothorax or any hypovolemic cause in the abdomen by doing a fast examination as indicated according to the history of the patient. Okay, next. We'll discuss rush protocol a little bit in detail. What is rush protocol? It is rapid ultrasound in shock evaluation. As I said in the initial slide, rush protocol basically is your pump, tank, and pipes. Okay. And the approach will be a high map approach. What is a high map approach? It is heart, the IVC. You see the patient in this approach, in this priority. First, you have to see the heart, then the IVCs, then the Morrison pouch and the EPAST, then the aorta and the deep veins, and at last, pneumothorax, pleural effusion, pulmonary edema, and all can be ruled out. Next. Yeah. Here comes the probe sequencing also for you for your rush examination. First will be the parasternal long axis view. Then comes the apical four-chamber view. Then the third is the inferior vena cava view. Inferior vena cava is below the Ziphy sternum, where you can see the liver. You have to fan your probe towards the liver so that you can see the IVC. You can see the portal vein joining the IVC and then differentiate the IVC. Okay. Fourth view will be the right upper quadrant, that is the Morrison's pouch view. Fifth will be the left upper quadrant view. Sixth will be the bladder view. Seventh will be the aortic slide view. So you have to slide from below to upwards, seeing the aorta, the abdominal aorta. Okay. The next two views will be the lung views, that is right mid clavicular line, second intercostal space, and the left mid clavicular line, intercostal space, second intercostal space. Okay. For the rush examination, you generally use a curvilinear probe. Next. Yeah, as I said, we see in a high map approach. So what do we see in that approach? For the heart, you generally see the ejection fraction. If it is reduced, then you can come to a systolic heart failure diagnosis. If it is a hyperdynamic circulation, you can think of distributive or a hypovolemic shock. If you see a pericardial effusion in the heart for the heart view, then you can think of tamponade. And RV strain, if you see a RV strain, then you can think of pulmonary embolism. If there is any regional wall motion abnormality, then you can obviously think of myocardial infarction. Low cardiac output states, you can think of cardiogenic shock or a hypovolemic shock. Okay. Similarly, when you see the IVC, you have to see the collapsibility of the IVC. If the IVC is collapsible, then probably the patient is in hypovolemic or a distributive shock. Okay. And if the IVC is non-collapsible, completely filled, then probably it is an obstructive shock, and it will also guide you for fluid therapy for the patient. If IVC is collapsible, then yes, you can give the patient fluids. If the IVC is non-collapsible, probably you should hold up upon your fluids. Okay, the tank, the pipes are already filled. The problem is somewhere else. Okay, so don't overload the pipes by giving more fluids. Morrison's pouch or the EFAS examination can guide you for a hemorrhagic shock if it is hemothorax or hemoperitoneum. When you see the aorta, always see for the abdominal aortic aneurysm and aortic dissection in the aorta slide view. As I told, the aorta should be seen from below to upwards. Okay. And for the pulmonary view, you rule out pneumothorax. Okay. Next. Next, please. Yeah. So what do we see step by step in a pump, tank, and pipe? Okay. So for the pump, step one is you should see pericardial effusion. If the effusion is present or if it is a tamponade. Tamponade is generally it happens when fluid gets accumulated in a shorter period of time, a larger amount of fluid gets accumulated. Okay, so that generally causes tamponade. Signs of tamponade on ultrasound will be diastolic collapse of the right ventricle plus minus the right atrium. Step number 2 in pump will be left ventricular contractility. When you have ruled out effusion, next see the contractility. How contractile is the left ventricle? It is if it is hyperdynamic, normal, or the contractility has decreased. Next step, we go to the right ventricular strain. Is the how do we identify the strain? Is by these signs. Is the size of the right ventricle increased, or is there any displacement of the septum from the right towards the left? These signs on the ultrasound generally indicate right ventricular strain. So we have to see, is this present or absent? In the pump, we go step by step like this. First, effusion, next the contractility, and then next the right ventricular strain. Okay. Then coming to the tank, you have to evaluate the tank for volume, leakiness, and compromise. Okay. So first we go for the volume. In the inferior vena cava, you have to see if the inferior vena cava is of the large size or small size, or you can see the internal jugular veins also. You can even see the IJV if it is small or large to assess the tank volume. For the tank leakiness, it's generally the E-fast examination or lung field examination where you rule out lung edema, and E-fast you have to rule out free fluid in the abdomen or thoracic cavity. For the tank compromise, generally it is because of an obstructive reason, basically a tension pneumothorax, wherein you will find an absent lung siding. So you have to rule out, you have to see if it is a tension pneumothorax to rule out tank compromise. Okay. Next comes the pipes. What do you see in a pipe? For abdominal aortic aneurysm, the abdominal aorta should be more than 3 centimeters. Okay, so if you see an abdominal aorta more than 3 centimeters, probably you are dealing with abdominal aortic aneurysm. Okay, next you have to see the thoracic aortic aneurysm or a dissection. How do you see? You have to see the aortic root. If it is dilated more than 3.8 centimeters, if there is any intimal flap, if the aorta is saying hi to you, that is an intimal flap. Okay, generally it is just the valve which you can see, but if something near the valve is saying a hi to you, that means it is a flap there. That is a sign of aortic dissection, thoracic aortic dissection. Okay, or if the thoracic aorta is more than 5 centimeters. Okay, this all indicate a thoracic aneurysm or a dissection. Next, step number 3 in the pipes is to rule out the femoral vein DVTs. You have to see if the vessel is compressible or non-compressible. Both the femoral and popliteal has to be seen so that we rule out any thrombus from there. Okay. Next. Okay, so here you can see, as I told, this is a case of pulmonary embolism with the signs of right ventricular strain. Okay, in the left side image, you can see a apical 4-chamber view, which is indicating enlargement of the ventricles, right ventricular enlargement. Basically, you can see the right ventricle is bigger than the left ventricle.